So, as we move to value-based care, we are doing so in a way that allows for all actors to get their feet wet and no one to drown. Where fee-for-service focused only on paying the negotiated rate for covered services provided, focusing on value actually started with bonuses superimposed on fee-for-service payments via programs referred to as pay-for-performance or P4P. Slowly, we're moving to value-based care with financial risk in a variety of other models. Let's take a look at some of these. Pay for performance includes foundational payments that are intended to help a provider initiate a value-based care program. Examples include the Federal Meaningful Use of EHR Incentive Program, which is now winding down, the Physician Quality Reporting System, PQRS, that ended in 2016, and which, along with the Value Modifier Program, is now replaced by the Merit-Based Payment System, MIPS, under the Medicare Access and CHIP Reauthorization Act, MACRA, of 2015. This updated the Medicare Improvements for Patients and Providers Act, MIPA, of 2008. An example of a foundational payment is providing a small incentive payment for care coordination for providers who are patient-centered medical homes accredited by the National Committee for Quality Assurance. So essentially, these folks were getting fee-for-service, and then if they provided care coordination, for which there is a code, they would get a small incentive above and beyond the fee-for-service that was negotiated. Shifting financial risk and value-based care includes a variety of models, which CMS refers to as alternative payment models. And this is where we don't just do fee-for-service with a little bit of add-on. We're actually making a complete different structure, but in a somewhat staggered approach. Shifting financial risk often starts with a shared savings arrangement in which providers are reimbursed based on fee-for-service but are eligible to receive a share of any savings after they meet quality performance and risk-adjusted standards. The next step might be shared risk, and that adds the dimension of the provider being at risk for the same portion of spending over the target as the health plan. So both the provider and health plan share equally in the risk. Bundled payment is a method in which payments to providers are based on the expected costs for a clinically defined episode or bundle of related healthcare services, including inpatient, outpatient, physical therapy, etc., as well as costs associated with preventable complications. Common bundles are those for orthopedic care, especially joint replacements, and we saw earlier how the costs of those joint replacements are so incredibly variable. Other bundles that are common are cardiac care and maternity care. Finally, full risk, also known as capitation. This refers to a fixed payment amount given to providers for the care that patients may receive in a given time period. This may be implemented partially where the fixed payment is provided for specific services only, in which case it's somewhat similar to bundled payments, but it's not as focused on a specific disease, or globally for all services provided, which would be the highest level of full risk. There may be some carve-outs for high-cost items such as specific drugs or medical devices. Full risk may also be offered with or without payment adjustments based on measured performance and/or patient acuity or level of risk. Finally, provider-sponsored health plans are not an alternative payment model being considered by CMS for its Medicare and other programs, but are an alternative payment model for providers to manage their own financial risk. And this is done by providers, especially large integrated delivery systems, who offer health insurance to employers through Medicare Medicaid Advantage programs or direct to the public. In essence, these providers are assuming all the risk, but also all the reward if they do well. So, provider-sponsored health plans are not a part of CMS, but an example is through a contract for the Medicare Advantage programs, or even just anybody at all in the public. Now, the goals that CMS set for itself for 2016 was 55% pay for performance and 30% value-based care. For 2018, pay for performance was to drop somewhat to 40% so that they could increase value-based care to 50%. So far, it's been a little bit difficult to determine exactly where CMS is in meeting these goals, but in general, the programs show satisfactory performance with goals met within a few percentage points of the goals.